So we have I don't remember how old she was. She was probably right around 60, 61. RGP wearer. She came in, she'd been wearing RGP contacts for 20 years, but she had not worn them in a month. She had a bit of a lamellar hole. It's kind of hard to see on her scan here, but there's a kind of a lamellar hole, a bit of a max schisis, definitely disrupting the foveal contour. And she's a high myope. So she's got a lot of things kind of happening. My first question for everybody here is, what's your guys' thoughts on RGP contacts? Even with a standard lens or with an LAL, what does everybody do? I mean, how do you work with your patients on when to stop them, or what's the discussion like? I'm genuinely curious.
Yeah, we have patients stay out of their RGPs each week, a decade. For every decade, they've been in the hard contact out a week of the contact. So if they've been in them for 40 years, they're out 4 weeks prior to when they come in for their consult.
We
That's
do a
pretty.
flat 3 weeks, get out of there, 2 to 3 weeks. Um,
There's a
before
high
we even
myope
take
too,
them.
because they don't want to be out of them for
No,
days. So we need at least a few days to try to see where they're at, I guess. And then once they get measurements, then they may be out of them for a week or two. But that's been difficult sometimes. So
What about patients who, like, we were crossing this right now? We have a patient that has no backup glasses. She's a moderate, I mean, she's like a -2 or -3. I don't think it's as
Mm.
high as this. Um, but has zero interest in doing, getting a cheap pair of glasses. So what do you consider for that patient? If she can't get out of her contacts, she's insisting on wearing them up until surgery. So what we told her is, especially, I mean, we would only do the light adjustable. We wanted to light adjustable ones. That's what we're going to do.
Right.
Um, I have no problem with her doing that, but I did tell her that she will be the process will be a lot longer. Is that fair? Would you guys say?
Yeah. I try to explain to them that it has influence on the corneal contour and,
Mm-hmm.
and all our measurements. And I show them the mapping and all that because we go through that together anyway. And I say, now we may be working with erroneous data. So we could get some surprises after that. Just with the light adjustable, we can address that, but it's going to take longer. And then I'll ask them even, can you go the weekend without them just to take a second set of measurements, just to even have something to compare, maybe?
Mm-hmm.
I've done that
Get a
before.
cheap pair of glasses because aren't there some places online where you can just get it made for? I mean, we don't usually support that, but I'm like, just to get her out of, I don't know, but
Most
Yeah, he
people,
said
that's what I would
she's
do. You give like 20 bucks on like Zenny or whatever, and they're gonna be
yeah,
crap glasses, but
right. But I'm
for
like,
just the
that way you can
weekend,
get some decent measurements. I just feel like her life would be a lot easier the 2 to 3 weeks while she's waiting for that to heal to like just have better measurements. But I mean, you only have one set of eyes. I kind of just push them like you can do whatever, but if you want to, a more
yeah.
seamless process that moves along and just a kind of a happier experience, maybe consider getting these glasses temporarily if it's not too much.
Yeah, that's typically what I do. I mean, we usually do, I think the rule of thumb is just like Jessica said, the 1 week per decade of wear. We almost always will have them out of them for at least 3 weeks, though, and most people are fine with that. I mean, most people do understand that and they're cool with it. If they don't have backup glasses, well, then usually that's exactly what we do, Jenny. We just tell them to get some glasses off Zenny for 20 bucks, and they're going to be terrible, but it's going to be better than nothing.
Yeah.
And that's fine. I think that's fine to do that. This one patient that I'm talking about, not this case, she was insistent. I think she had some weddings coming up, and it was a big deal. So I said, fine. The reality is we at least want to be within 2 diopters. So we hope that we're within 2 diopters so we can adjust it.
Yeah.
But I told her, like, it's going to take a lot longer. We're going to treat you as if you had RK, basically, where your first adjustment is not going to be for at least a month. And then we'll do kind of benchmark testing. We're going to see where your refraction is. And once we've kind of established that it's stable, then we can go ahead and proceed with the treatments. But it's going to take her probably 2 to 3 months at least to get through this. And she was okay with that. So, okay, fair enough. So we proceeded. That's not this case though. This patient was out of her contacts. She was well educated coming in. She knew that she had to be out of them. She had a fair amount of corneal cylinder too, and her topography looks like that. So she's got a lamellar hole in one eye, and then in the other eye, she's a cone. So we've got kind of a double whammy here, 2 separate issues. So obviously, I mean, we wouldn't want to do, this is an LAL all day for us. Would anybody do an LAL versus an LAL plus? Or an LAL plus versus an LAL?
I would do an LAL for the left eye.
What about for the right eye with the hole, or the lamellar hole?
Also regular LAL, but
Yeah.
I mean, we did both LALs.
Hmm.
I don't think I would be bold enough to do a plus with this one. I would just be a little nervous. I think some docs, and there's probably no wrong answer here, but I would be a little nervous to do a plus in somebody like this because they've got an aberrated cornea for sure. And then that spherical aberration could be influenced by the irregular macula and just leave her with a not perfect outcome. So yeah, we went with the LAL, just standard. Oh shoot, this was supposed to be animated, so it gave away my. Hold on. It's supposed to be animated. Okay. to leave a little a surprise here. Okay, so here's what we did. We did bilateral LAL on April. This is about a year ago. Outcome right out of the gate was like really good. Damn near plano on the right eye, 2015, and her left eye, with all that corneal irregularity, she had about 2.5 diopters of astigmatism. So next question for the group: would anybody just wait and give it another week or two with this refraction, especially the left eye?
yes.
Would you wait?
And that's what I was going to ask too on, general consensus is, are
Mhm.
you treating your cone patients similar to an RK, like somebody with very variable corneas?
Mhm. I would. I think in hindsight I would have. I didn't in this case,
Okay.
but I do. I am much more. I feel like I've learned a lot from this group, especially over the last year, where time is your best friend, man. You don't have much. You have a lot of things in control, but one of the biggest valuable things that you have is simply time, and you get 3 chances to do that. So, hindsight, yeah, I would have waited. I wouldn't have treated her, but I did treat her. I did. And she really wanted to have a blend. And being that her right eye we didn't really know which eye was going to be her dominant. She definitely leaned right eye, but we weren't really sure what the potential was in either. And I think that's I get that question a lot. Do you do mix and match LAL versus LAL plus? And I usually don't like doing that. And that's, a lot of surgeons do. I don't, because you don't really know what the potential is going to be. Like this patient here, we don't know if the cornea is going to be a bigger problem or if her retina is going to be a bigger problem. So once we got the cataract out, turns out her cornea clearly is the bigger of the 2 problems. And so we wanted to leave that one as her non-dominant reading eye and kind of preserve the distance vision for her right eye. So now, anybody have any suggestions on what to do for her treatment? Because we want to make her right eye distance. That's easy. Her left eye for reading. Anybody have a suggestion on the target? What to do?
You
So
would
this
target
is
plano, right, in the right eye, right?
right eye plano. Yeah, for sure.
Now they're gonna need
Left,
probably a contact lens again in the left eye anyway if they have keratoconus. You're not gonna solve that problem. So
maybe. Yeah, maybe. We'll see. We'll see. But the big thing here that you wouldn't want to do, because of she's gonna have a lot of coma as a higher order aberration. Also some spherical
Good
aberration.
idea,
She'll
so.
probably have a decent amount of negative spherical aberration already. So you wouldn't want to trigger that added depth of focus. So this is an example of tricking the system. I think I talked about that last time. And is everybody familiar with that concept? Okay. So just to kind of recap, in order to add depth of focus, you have the ability to do it. on the first treatment. So on the first treatment, if you move in the myopic direction or stay neutral in both meridians of your power cross, and your target is -50 or more, you will add an added negative, it's like an eighth of a diopter to a quarter of a diopter of depth of focus, which is not a lot, but it's enough to make a difference in the right person. It's also enough to be problematic for the wrong person. So if we did that in this patient, I was worried that that was going to create ghosting, glare, halos, all those negative things that you hear about, even though it's her near set eye, and I was nervous about doing that. So if we were to target -75, it would trigger that depth of focus because both meridians are now moving either myopic or staying neutral. Our target is -50 or more, and that's our first treatment. So you're meeting all three of those criteria. So what I did, so right eye did plano. Her left eye, I just treated the astigmatism. I didn't treat the spherical component. And I think, and I don't know if there's any value to this or if there's any legitimacy to this theory, but I do feel like if you're moving the macromers in one meridian only without influencing the other meridian, it kind of makes sense that it would be a little more accurate, right? I don't know if that theory, if you guys have noticed that, or if that's the strategy that you've done. But if you can isolate one meridian out, again, I'm not a polymer scientist. I don't have a PhD in chemistry or photochemistry, but I feel like it probably makes the accuracy of your access a little bit more predictable. Does anybody have any thoughts on that? Or am I wrong? Am I crazy?
No, I think the system's doing that on a lot of the patients. If you see, like sometimes I'll have them back and only one of the two is fully corrected and then the other one is pretty much exactly the same. So I'm seeing that trend. I don't know if it's with the latest update or what, but yeah, I think you nailed it there of it targeting one meridian first, you're going to have a more concise outcome.
Yeah, I think you're just more, and I mean, this theory is supported by anecdote. I mean, this is what I do often for patients, especially high SIL patients.
That's
And
what I was gonna say. For high SIL, I feel like that's a really good way to go about it because I've like low SIL, I've targeted a little differently, and I can go through that in my case next. But for this high SIL, I probably would have done the same thing too, just for the more accuracy.
yeah, and then we're not getting that depth of focus. So she came back. So this is a week later. She's 20/20 in the right eye. She's 20/30 in the left eye now. We overshot it a little bit. So she ended up -1 in the court. Well, we didn't overshoot it. We were spherically equivalent, basically where we wanted to be. We just didn't get all the cylinder. So, and I don't know exactly how the machine decides what it's going after, but we are at least pretty consistent with the axis, which I liked. I liked seeing that. And so we ended up going just a little bit more myopic. She liked that reading. She wanted more of it. And so I ended up targeting -1 1/4. Again, by doing this as my target, I'm isolating one meridian completely, and we're only focused on the macromers in the other meridian. I think there's an advantage to that. So she came back then, when is this? This is a week. Yeah, a week later. And now we're at target completely. So we neutralized 2.5 diopters of astigmatism. She is -1 1/4. And I've seen her since then too. So I've seen her. I think I just saw her not long ago, actually. That's why I thought of this case. And she is still holding steady. She's still very, very happy. And we have not, I mean, the astigmatism is gone, 2.5 diopters. And this is our final lock. So really everything, this is back in July, I saw her, holding steady. So 20/20, and she was actually correctable to 20/20 in the left eye, which is pretty surprising with her cone the way it is. Very happy. So
And
that's,
she was a
yeah.
GP wear prior to this, right? Or no?
No, yeah, she was. I'm sorry, she was for 20 years.
Nice.
Yeah, 20 years. So kind of a complicated individual. High myopes can be tricky too. I mean, because they're so used to the world in a certain way, and she was very pleasant. She was very kind of type B, which is unique, I think, for this. You don't get a lot of type B LAL patients. So she was very tolerant and she was totally chill. And with that high of myopia, I was, just on the surface level, and these two separate issues, I was a little like, this is going to be a bit of a challenge. I mean, I would pick the LAL all day for this patient, but it just comes down to an expectation issue for her, that are we going to really meet what you think is going to happen, because you're so used to seeing your world through RGPs or negative 10 diopter glasses that things are just different. So yeah, I thought that was an interesting case.
Do you guys find that a lot of your high myopes, even if they're able to read that J1 plus line, still say that they feel like they need some readers when they're reading?
Yes.
Yes,
Okay.
all the time.
Right? And you're like, I can't even read that tiny line, but they're just like, yeah. But they're happy. I always try to always set the stage for those high myopes. So I'm like, you are really used to having
Yes.
everything magnified. So we're going to get you some functional vision, but you'll probably feel the most comfortable when you're wearing +1s. And I think by saying it from day one, then they're not that disappointed when we're starting their lock-in, and they still feel more comfortable using that light reader.
I have started doing that, especially with the high myopes, because they just are like, they're just used to that. And I tell them, like, you're used to basically having magnifiers when you're looking up close, not even necessarily the high myopes, your -3s and 4s, because they'll whip their glasses off and read all day long. You're like, okay, we're gonna flip everything upside down. And we talk about that for quite a bit before they go to surgery, so that they try to have a realistic expectation. Because I was a 375 before I had mine, so I had to do it. And I will throw on a +1 if I'm going to sit a long time. I never put it on day to day, but there are certain times I may even do it, because I have a habit of holding it. It's like, push it back, man. You're a 375. Stop it. And I know the deal. So it's
Yes,
good to set the stage.
that's what it is. I feel like for most of the patients too, is just reviewing, expectations that you can't hold here anymore. I'll ask them. My first question will be like, what do you mean you can't see anything up close? You're reading really good. You're seeing the bottom line on the near card. And they're like, no. And I'm like, well, show me, what you can't see and what you're struggling with. And they'll pull out their phone and they'll hold it right here. Like, this text. And I'm like, okay, let me show you. This is going to make it a little bit easier. And they're like, oh, just because that's what they think this is normal. So I'll actually have them pull it out and I'll say, show me, but not explain anything, so I can see exactly what they're doing. And then that's when I'll have them hold it at the normal distance. And I'll say, here, if you want to hold it closer, here's what a +1 would do. And I'll hold up a +1, over both eyes, like a +1 reader. And they're like, so if I want to hold it here, I can. I'm like, yes, but that means you're going to have to use a reader.
Yeah. And I also try to remind them, I'm like, this is like PT for your brain and your eyes right now. The more you practice it now, the less dependent you'll become on the glasses, because it's going to be comfortable to put it on. But I'm like, hey, if your goal is to get rid of these, then just keep practicing. And I promise, these are like new eyes for you. You have to learn a new working distance.
Yep.
Yeah, totally. Jenny, I think you don't let your patient, I mean, you were the one who I think introduced me to really restricting patients from their reading glasses. And I think that's a great idea, because you're totally right. It is physical therapy for the eyes.
Yeah.
And you have to learn a new skill. I mean, what is the easiest way to go downhill skiing? Well, don't go downhill skiing, right? You're learning a new skill. You got to start somewhere. And these patients are used to it in certain way that if you don't train yourself, they always complain, right? They do always say that it's better with my reading glasses. Well, naturally, because your reading glasses will magnify things.
Yeah.
But don't rely on them,
makes it
because
bigger.
it makes it bigger. Yeah, it makes it bigger. So don't. Otherwise, you're never going to get used to it. And
As we're
I always
sitting at
call
the
them out on it.
machine. Oh, sorry about that.
What? What'd you say?
I didn't mean to interrupt, but as we're sitting at the machine after the first adjustment, I'm like, okay, starting tomorrow, you're going to put your readers away and you're going to start practicing letting that near vision go to work for you, but you're going to have to learn how to use it. And that's something new I've started not that long ago at that first, I let them use the readers till the first adjustment, of course. And then I'll go, okay,
no cold turkey.
now it's time to put those to the side.
Yes, hide them right
Resistance.
now.
Yeah.
Yeah.
And then I also, if you guys have time in your exam real quick, have them pull out their phone and go to their settings. Because you'll see at least 50% of your patients, their font on their phone is so tiny. And you're like, of course you
Yes.
can't see that. I can't read that. Like they think that if they keep pushing themselves, they're working their muscles. I'm like, just make it a little bit bigger. So then, they're not that efficient with their phones. So I will just change the settings. Under accessibility, you can make it, the font bolder, the contrast higher, and then I just bump it up. If you go to large text, 2 to 3 up. So it's not going to take up their whole screen, but it's definitely bigger than that tiny, tiny print that they have at like the default.
Yeah.
And
I've
the
gotten
same
pretty
thing,
used to doing that for the patient.
Mhm.
Like I know exactly how to do that real quick now.
Exactly. So I
Yeah.
just swipe it real quick because they're not
Yeah.
going to do it at home. It's just not that easy for them, which is fine.
Yeah.
yeah, same thing goes for computers too. A lot of patients don't realize you can enlarge the font size on your computer. So for people that are on the computer for, extended periods of time, all day, especially near the end of the day, I'll tell them, you don't have to put a reader on if you want, just enlarge the print. And then they come back the next week and they're like, I'm not using glasses at all at the computer all day.
Yeah. And with PCs, if you just do Control Plus, that just makes everything a little bit bigger.
Yeah.
And if they don't like
Yeah.
it that big, Control Minus will bring them back. But I use that a lot now. I'm like, oh.
I always call them out. I try to like enter the room without, I usually knock, but kind of lightly and then walk right in. And I always catch them like on their phone. And so I can kind of use that. Like, I saw you, you're
Yes.
lying. You can see just fine. I
Can
know.
see,
Otherwise,
right?
I had to do that to a patient. They're like, oh, I'm not sure I can see my phone. I said, you were looking at it when I walked in. You were scrolling. They're like, oh, I guess I was.
Yeah. You're just looking at a blank screen there and they just scroll. I can see you're reading something. Yeah. No.
Or they
You
can't see
bullshit
their
a bullshitter
phone
right now.
and it's like their calendar app with like, I don't know if you guys have seen that where it's like a reminder on the calendar and it's like probably smaller than J1 plus font. And I'm like, okay, well, this is really, really small print. I even am having a hard time reading that.
Jess, do you want to share your case?
Yeah, one thing I did want to mention on your case though too, Nick, is I just want to get your guys' thoughts on how you guys educate patients who have a lot of astigmatism, what to expect with their first adjustment. Because I think a lot of these patients think, oh, this first adjustment, I'm going to be at target. But as we know, if a lot of astigmatism, sometimes it takes a couple adjustments. And they'll often ask, am I going to see up close like after this adjustment? I just want to hear what you guys typically say and how you educate the patient.
Yeah, usually, I think setting expectations is really important. I think the harder thing for those patients is between surgery and the first adjustment at all. Like, that patient that I just had was 2.5 diopters of uncorrected astigmatism. And we knew that she was going to have a lot. We didn't know how much or where it was going to be. We didn't know if it was really going to be with the rule or against the rule because her cornea was, cone. So we told her that one eye was going to definitely be better than the other. We didn't know which eye was going to be the best. And thankfully, she's the right person. If she were incredibly type AAA, that might have been more of an issue. It was pretty easy going for her, but I could imagine that there may have been a little bit more of a difficulty for for the wrong individual. I have made, like Jenny, your point earlier about making cheap glasses. I have done that. For instance, I had a lady who right now who has she's a pretty big esotrope. She's got diplopia, and we told her from the very beginning that you're not getting rid of glasses, but she's not as double up close, and that was kind of her big thing. And so she wanted the LAL. She was firm. This is what I want. I've done my research. I want it. Okay, fair enough. And then right after surgery, she's complaining of double vision, and she's a little upset about it. I'm like, I told you, you're going to be double. And so what we ended up doing, because she's pretty much dead on plano. Right out of surgery, she was maybe a low plus. I ended up just like empirically prescribing plano glasses with whatever prism she had in her habitual. And she got them made at the 24-hour store down the street for $50, and it's fine. So for those patients, that applies to the high SIL patients too. I think that you can do that. It's a Band-Aid. It's a part of the process. And I think the natural question is, who pays for that? Does the patient pay for it, or do you, the doctor? The patient has in our case, and the times that I've done that. But if they pushed me on it, I don't really know. if what would be the most appropriate part of the package. What do you guys think?
I think it's on the patient. But then a
Yeah.
lot of times with that patient that you had, usually it's one eye that's really bad. And then the other one can kind of hold them over. So usually they're seeing, this lens is pretty forgiving. Even with the 250s still, she was seeing 20/60, but in the other eye, 20/20. So I feel like in most of the cases, there's at least one eye carrying the other one so that we can maybe avoid the glasses if necessary. But I think if they need it, then that's kind of on the patient, and just because it's
It's
temporary.
probably, yeah, I don't know. I think that's an interesting question. Like,
Mhm.
part of the package. It depends on how concierge type service you want to have, I guess.
What about just a contact lens to hold them over?
I don't have contacts.
Oh, yes.
I've got a few laying around. I have used a contact lens to hold them over. I don't love it. Just I'll use like a daily or something because we keep them around. We call them for blending, like, just to test drive something.
Mhm.
I have a couple patients that are pretty picky, so I'll give them a contact lens and a daily to use to test drive before I do an adjustment sometimes for a few days. So I have some contacts laying around, and I'll use those for some folks if I've got something that'll help them.
I started ordering just a small batch of trials. I have trials from +2 down to -150. And so just order to try, like, because you have a WVA account or like a contact lens account. And so I'd say just maybe order a 10-pack of trials to have it in your office, just so you have it in case to hold patients over if they want to test a little blended vision. I don't know. It doesn't cost
Yeah,
anything.
I've got a handful of +50s. I mean,
Okay.
that's usually the only time that I would consider that I do it. I don't do contact lens trials that often, because I did at the beginning, and I found that patients were driving themselves nuts, and then it was giving the patient too much freedom, I think, to test drive, and then they would come back and be, at least one patient I can think of off the top of my head, it was like really in her head, because she's like, well, then I want like a +75, and then I want a +25 and +50. And now we're like splitting hairs so much. And
Yeah.
like, then she couldn't make a decision, and she kind of spiraled, and this was a psychological thing. I mean, this was definitely where I was playing psychologist, not doctor. And we're just talking her about like, well, like, this is just your second treatment. It's not even final. So it was kind of a mess. So, but I do keep +50s around, only to determine if they can tolerate a blend. Um, but I don't really keep anything else. But this patient, I wouldn't have had a +250 cylindrical. I don't have
Mhm.
that.
Sure.
Yeah.
Um, we could do a spherical equivalent, I guess. But she was fine. Like you said, I mean, one eye is always better than the other. I guess I'd cross that bridge if I get to it. I mean, I always have the ability I mean, I live with another OD who's got contacts. I can just ask her for one.
Well, the
I
nice
have
thing
access.
I figured out too with these patients lately is that RxSight does have these fit over glasses. I don't know if you guys know about these. I just found out about them not too long ago. But so if you get these temporary glasses, patients can wear these larger,
Oh,
fit
yeah.
over UV protective glasses. So that's saved us for some of these patients that have had a lot of cylinder coming into their first adjustment. And then I find, like you mentioned too, with the first treatment, it'll treat like the spherical equivalents. They won't quite
Mhm.
have all of their SIL adjusted on the first adjustment if they have more than like 1 to 1.5-ish.
Mhm.
And so I'll typically let them know that the shadowing ghosting will get a little bit better, but it may not go away completely with the first adjustment. Near may come in a little bit, but don't be alarmed if it's not in completely yet with the first treatment. And we'll have those other adjustments to fine tune it. But I do think these high cell patients are a little more challenging just because they're the ones that are typically the most frustrated, or they're the ones that call you a couple times before they come in for their first treatment. So these ones we try to educate a lot on, prior to their consult. But like your case, like you mentioned, she had one good eye to kind of get her through. So this would be more, I guess, theoretically for someone that has more cell in both eyes. But yeah, so I have a case too that I wanted to share about, similar to what you talked about too, Nick, with tricking the system. And then it's also a retinal case on someone I didn't activate the extra EDOF on. Can you guys see my screen right now?
Yes.
Yes.
Yep.
Okay. I'm gonna minimize you guys, sorry. I don't know if you guys, can you see if I have you guys there, the pictures of yourselves too?
No,
No.
no.
Oh, okay. Okay. Let's see. So I'll pull up the slideshow. Okay. So this is the patient at her cataract consult. So it's a 69-year-old female. She wears glasses full time, no history of contacts, no history of monovision. She had macular hole repair with a vitrectomy in June of 2024. That's her MAC OCT though. So as you can see, that's in my opinion, a beautiful surgery. A little irregular foveal contour, but overall pretty good. So she came in complaining of blurry vision. Her cataract was worse in that eye since she had a vitrectomy, but also complaining her cataract's blurry vision in both eyes. She wanted as much glasses independence as possible, and because her husband had LAL, she's like, I want that too, and I want the same vision as him. So of course we had to set up expectations and everything. But this is her spec RX at the bottom. So she was a hyperope. The right eye best corrected to 20/20 -1, left eye best corrected to 20/60 -2 or 20/60 +2. But she did have a more brunescent nuclear cataract in the left eye than she did the right eye. We actually will utilize PAM on these patients to see what their estimated best acuity will be if without the cataract. So it estimated with her macula, she probably had 20/25 potential. So we went ahead and proceeded with LAL, not LAL plus, just because of that reduced visual potential. I think with this scan, some of you could argue LAL plus. Of course, though, with any maculopathy or macular surgery, there's that reduced contrast in with activating negative SA or anything like that. You could just continue to reduce their contrast. So we were a little more conservative and just did LAL in both eyes. So at her first visit, she came in uncorrected vision in the right eye is 20/30 -1 J10 and left eye is 20/40 J16. So she was refracting just mild hyperopic, mild hyperopia of some cyl in the right eye, and then just a little bit of cyl in the left eye. This is where we targeted Plano in the right eye, and then on the left eye wanted an end goal of -75, but didn't want to activate that extra negative SA. So I put in the machine, as you can see on the right-hand side, +50, kept the cyl the same, and then targeted -1/4. So still there's a delta of -75, but didn't target -50, so only -1/4, so not reaching any of those requirements. But again, this is kind of what Nick was talking about, where do you isolate one axis or not? But she came back at her follow-up on January 6th, about a week later, the right eye, by treating that little bit of hyperopia in the cyl. For some reason, I still ended up at +1/4 with the MR. She was 20/15 J5 left eye. She ended up right at -75 with 20/25 -3 J3 -1. And targeted Plano in the right eye, used some trial lenses to show her different options for the left eye, and she wanted -1/4. And then came back a week later with treating that +1/4 in the right eye. She was 20/15 J3 -1. And then the left eye, with going a little more myopic, she went to 20/70 +2 J1 -2. And she was just saying it wasn't crisp. She did have some PCO in that eye, although it was mild. I went ahead and said, let's do a YAG today just to clear that up, give her as crisp as vision as possible. I did get a MAC OCT that day too, just to make sure there wasn't any CME or anything after cataract surgery. And then came back on the 20th and went to 2040, still about J1 minus 2, but saying it was crisper, happier after the YAG. Again, ended up at Plano minus 150. And so she ended up a little bit more myopic than what I targeted, but she really liked that amount of myopia and wasn't having any issues with anisometropia. So we went ahead and locked in. And then lock into the left eye, a little bit of a decrease the distance. Sometimes between lock in 1, lock in 2, patient's dry eye will flare up a little bit, and sometimes I'll see a little fluctuation. But overall, she was really happy. Her final outcome, as you can see, OU was 2015, J1 minus 2, and that was with LAL in both eyes. Obviously targeting a little more myopia than the blended vision, though. But yeah, I just thought that was a really cool case given her macular repair surgery and the vitrectomy.
Yeah, I think that's great. You did everything that I would do too. I mean, you probably could argue doing an LAL plus. I tend to be conservative with the plus versus the traditional, only because I mean the two lenses are so much more alike than they are different, and you can get a great outcome with the LAL with really just a little bit less risk. So I would do an LAL in that case, and I would avoid the negative SA also, just like you did. I'm curious. So you did a YAG. How quick is everybody here to pull the trigger on doing a YAG? That's the golden question. Some doctors are like super gung ho about it. They do it right away.
We were going to bring that up today.
Yeah, I have
Yeah.
those questions also because I've had several. I'm very novice to LAL, so pretty much my past 3 patients have had PCO right pretty quickly after surgery. So I did. We ended up doing YAG on 2 of the 3. And I'm not sure either, though. I'm trying to figure out how visually significant it is. Some of them, are like correcting to 20/20 minus, and one had a PSC, so that one I'm thinking probably will need a YAG, and so that's definitely something we're trying to figure out too. Is where in the process you do the YAG if they're going to need it at some point.
Yeah, I do find that these patients get PCO a little bit more because they're silicone implants. So silicone is a little more prone to develop PCO than acrylic lenses. So I do see it, and I see it about 50% of my patients, I feel like, but I YAG probably about 20% of that 50%. And a lot of it has to do with if they're not refracting to 20/20, or they're complaining, like this patient's case, that it just wasn't crisp, and she was complaining it's almost like smudged and or like shadowed or ghosted, but you're not picking up any astigmatism, or they're complaining of glare. They have the PCO complaints, but sometimes it's just not crisp or clear, and it could be very mild PCO. Like in her case, it was traced to 1+. But it was enough that once we yagged, there was a big difference in the crispness of her vision.
Yeah, I say try to hold off on it until it's actually visually significant. Like Jessica said, if it is blurring their vision, not correctable to 20/20, or they're complaining it's like a foggy haze, too much glare at night. But I'd say like 20/20 minus, that would have been fine to continue, just because you want to save it just in case. One, for that wow factor for the patient of like, okay, it's blurry and then now it's clear. And then 2, just in case they might need, an extraction or something later on. Not common, but you want to try not to YAG that if possible.
I used to be one of those docs that wanted to YAG early, and thanks to this group, Jennifer in particular, I started listening, and I now wait. It needs to be significant. If they have a complaint, sometimes we'll do a bat just to see if that's doing anything once I've refracted them. If they're refracting crisply, I don't go to YAG like I used to. It sometimes it doesn't help, and you've limited options down the road for some reason. So I'm now an advocate of if it's affecting your refraction, or if they have specific complaints like Jessica's described, then absolutely consider it. But otherwise, hold off. Don't do it.
Thank you, guys.
Another
Yeah.
thing I've started doing is to save some of the macromers in their non-dominant eye, I leave 0.5 sil in their target so that you don't have to go backwards and then come back. It just, so to me, I'm just like, I've been dabbling with it. So then most of the patients end up like -75, -50, and they're so happy. They're done with one treatment. You start locking on, visit 2, everybody's happy then. Less chair time for you, and still reading is crisp for them. That was, yeah.
Do you do that, Jenny,
Brilliant.
in a particular axis? Is it always with the rule, or is it against the rule, or is it?
No, basically anyone that I trial frame them beforehand, and if it's still nice and clear, there's like a small handful, I'd say maybe 5 to 10% of my patients where it's like, if I don't fully correct all their still, it affects their distance. If it's not affecting their distance, intermediate or near, I just leave it. And yeah, I think Susan said that, be careful with some of the oblique sills, but so far I've kind of left those 2 and they have all still been happy. So just something to maybe chew on, just to save you guys time and save the macromer. That's the other thing. Like if they have a higher prescription, then it's like, well, let's just not correct all of that still and see how you do. I mean, worst case, you can always try to clean it up later, but you'll be surprised at how happy the patients are.
One thing
So
I'll
go ahead, Jess.
One thing I'll find with one thing I'll find with that oblique cell too is sometimes it'll be dry eye related. Like I'll look back at their previous visit and I was refracting spherical like +1/4, and I treat +1/4 and they come back the next week and they're I target plano and they come back the next week and they're plano +50 at axis 20, and I'm like, well, I know that can't happen because they didn't have any still last week and I targeted plano. I can't just create sil out of thin air. So a lot of times I'll treat their dry eye and they come back and they're plano and that oblique sil goes away. So be careful with that oblique sil, especially if the AR is picking it up. In your MR, a lot of times you can kick that out.
So that brings up a case.
Okay.
I had a question kind of for the group. I was talking to a friend of mine just yesterday, and it kind of got me thinking about like when do you chase small amounts of refractive error? So, for instance, this case that she had, it was a standard LAL. It was plano in the dominant eye, and he ended up +1/4. And then she said that during surgery there was some noted zonulopathy. And so the thought is that the lens drifted a little bit after the first lock. So it went from +1/4 to +50. Now the patient's still happy, but he did notice, well, maybe it's a little blurry, but he was happy overall. And so she was asking me, well, do you try to treat that? And I know we talked about this with the group before, trying to make a treatment in between the 2 lock-ins. Has anybody tried that ever since we first talked about it? With success, or?
Most of the time, if it's +75 or less, yes. We've had success getting them back to plano. And usually
Very small.
Yeah, symptomatic, and then repeatable 2 to 3 visits after, just to make sure it's not tear film, just irregularities. If it is there, definitely worth a try to do that T4 treatment before that.
Okay, so doing it, do you type in plano then as your target, or do you try to kick in the wind, like overshoot it a little bit?
No, just because one time I tried to overshoot it and it hit the target, and then the patient was way. So then it's like, just try to go, because for some reason that T4, that first treatment, gives a little bit better kick than any of the other treatments, in my head at least. So let's hit it. So
well, that's what I told her. I had never done it. I haven't found the need to do it because 20 happy is really, if they're happy, I'd just like, cool. Especially if they're hyperopic. If you're hyperopic in a distancing eye, that is not a problem. I don't get too focused on the actual numbers. If they're myopic, that's a different story, because then their distance is no doubt compromised. It's a slippery slope, more so on that side of 0 than it is on the other. So if they're +50 or so, and I'm not perfectly happy with them not being on plano, I'll leave it. But if they're like -1/4, that is usually noticeable, and then I'll try to treat that. But I told her, my friend who was telling me she was case, I said, go ahead and try to treat it. I had no success. I know last time we talked about it, I think there's a lot of like, yeah, maybe it was placebo. I don't know, but it's good to hear that you've actually had success doing that. And I'll let her know, and that'll give her confidence to do it.
Mhm.
Okay.
But with that
cool.
patient, if he was 20 happy, I don't know. I don't know if he'd notice any improvement. I mean, these patients were like definitely adamant that they noticed a big drop in their distance vision after lock-in 1. And then, yeah, so I don't know if it would be worth it to mess with that patient.
It's like one of her first cases, so she's like really paying attention to this one.
Oh, got it.
And he is happy, which is good. I mean, that's what I wanted her to experience. That this is awesome. The patients are happy with this. So don't focus too much on the numbers.
Yeah.
And especially in the non-dominant eye too. I do get doctors when I talk to them sometimes about this. They focus on like, well, we only got to -1 and not -1.25. Well, 20 happy I think is even more real in the non-dominant eye, because -1.25, I mean, that's all kind of working distance. And you do have depth of focus with this, where -1.25 and -1 a lot of times operate the same way. Those are very similar optical zones, especially if you induced the negative spherical aberration. That's why it's so great to have it, because that gives you more range of vision.
Mhm.
So I really don't focus too much on the numbers on the non-dominant eye. It's when that patient comes back and they're happy, awesome. I don't care what number you're at, as long if you're happy, let's lock it in. Even if there's a little bit of cylinder. Jenny, I'll take your word for it. I mean, that's probably good advice to leave a little bit of cylinder. I would be more so inclined to leave it if it were with the rule,
Mhm.
because especially in a young person, they're going to drift, and they're going to drift against the rule over time. It's like a quarter diopter every 10 years, I think. And so if they're like a 50-year-old and you've got plus 50, like at 90, awesome, that's great. That's going to kind of mellow out. And it's going to be usable too, in the short term, because that's an old refractive trick, is just
Mhm.
leaving a little bit of that to try to enhance depth of focus. So I think it's great advice. Buddy, you got anything to contribute? No? Okay, cool. I've got another case, but I think I'll save it. I'll save it for next time. I don't want to. Yeah, I'll save it. Anybody else have any thoughts? Anybody else have anything they want to add?
How many of you guys, if someone's coming in first day, first treatment, and they're 2015, you got to do something, right? You got to do either neutral but you're refracting some cylinder,
Mhm.
and you put it in front of like, wow, that's much better. Are you guys correcting that cylinder that first day, even if they were 2015? And they want distance, so let's keep it that.
Yes. If they notice a significant difference, it's there.
Yeah.
Yeah,
I always
trial
stop it.
lenses. Trial lenses or trial
Yeah.
frame are my best friend. So if I ever am unsure if it's a really small treatment or tweak, I'll get out the trial frame, I'll have them put it on, or I'll use trial lenses with the sill. I have to use the trial frame, and I'll have them put them on, and I'll say, do you notice a difference? If they don't, I leave it. If they do, I'll treat it.
I think it's a
So if they
perfect
didn't notice
opportunity
it, would
to.
you do a neutral adjustment that day so you can go for the lock in the second time, or are you steering
I would
towards that little bit of sill?
I would just treat it, and I usually
Mhm.
like the trial frame. I think is great, but I would also show them like outside. We have windows in our clinic, so look way far away. So there is no, short room induced over minusing happening. I mean, you look at it far away, and if they notice a difference, like looking out at the trees 100 yards across the parking
True.
lot, it's there. Yeah, it's there. Do it. And they usually come back and they notice it too. I kind of warn them that, well, you may not notice much, and 9 times out of 10 they come back and they're like, holy cow, that made a huge difference. So
Yeah.
yeah,
Which is
you can be
crazy because you're
confident.
like, you're reading 2015, but I'm like, I mean,
Yeah,
this lens is amazing. It has the best optics I've seen in any other IOL.
Yep.
yeah.
And
You
it'll
don't have to
kind
be
of
afraid
help
of treatment.
it'll help their near a little bit sometimes too, by treating that little bit of, if it's plus sill, you treat it
Mhm.
to plano. Sometimes you'll see their near get aligned better in that eye too.
Yeah, I think you can be comfortable doing that. Awesome. Well, guys, I think I'm gonna put this one to bed. It's past his
He looks
bedtime.
tired.
Oh, he's so cute.
It goes
Man, I
fast.
got
man.
basketball games to watch.
Enjoy it.
Yeah, we'll have another one of these probably in the next 6 to 8 weeks, sometime probably early May. So be on the lookout. But awesome chat, guys. Appreciate all the feedback.
Yeah.
Every time we do this, I learn something new. So this is
Me too.
we'll keep doing
Great.
Me too.
Thanks, guys.
Thank
this.
you.
Awesome, guys.
Happy
Have a good
spring.
night. We'll see you.
Take care.
Bye. Have fun watching the games, everyone.
Bye.